So I think we should start right now. So hello everyone. I would like to welcome you all to this wonderful lecture. It's part of the series of the Cornea to the Wonderland of the Sinjab Academy. On behalf of Dr. Mazen Sinjab, I would like to introduce Dr. Professor Mohamed Hosny from Egypt. He's a well-known cornea and refractive surgeon. And the title today is catching title, No Bubble, No Trouble. So hello, Dr. Mohamed Hosny, and the mic is all yours.
Okay, I'll be sharing my screen just now. Okay. So you can see my PowerPoint presentation, right? Okay.
Yes.
So, Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, everyone. The presentation of today is intended to be short and sweet. I want to deliver a certain message. For those who did not or who never heard me before, my name is Mohamed Hosny. I'm a professor of ophthalmology at Cairo University, Egypt, and my talk today will be regarding lamellar refractive surgery, basically DALC surgery, so deep anterior lamellar keratoplasty. Now, deep anterior lamellar keratoplasty has been on vogue for the past like more than 15 years. And the real breakthrough happened when we all started to adopt the technique of Professor Mohamed Anwar, which is the big bubble technique. Again, lamellar keratoplasty or deep anterior lamellar keratoplasty has been done over the years, and it was challenging to do before we learned how to separate Descemet's membrane from the whole part of the stroma. We used to do it in a crude form, and so we didn't get very nice visual results or visual rehabilitation. We really had good anatomical results. I remember we did lamellar keratoplasty back in the day manually, even back in the 90s. But we always knew that in these patients, you would find that the patient looked very nice on the slit lamp, but the visual outcome and the vision of the patient was much less than expected. And so people started to abandon the concept of doing lamellar surgery for corneal transplants until Professor Anwar, actually not until Professor Anwar published his technique, because he published the technique a long time ago. But then, for some bizarre reason, this technique began to become en vogue, and people started using it and telling each other. And then, when we started using the big bubble technique and separating the whole cornea from the Descemet's membrane, or the Descemet's membrane and Dua's layer, of course, I'm a strong believer of the existence of Dua's layer. So when we started doing this, we started getting the best of both worlds. You would do an extraocular procedure that would end up with, transplanting only stroma, and so a lot of complications or potential complications of penetrating keratoplasty were definitely avoided. And on the other hand, you would get good visual outcomes, unlike the manual anterior lamellar keratoplasty, where we did back in the day, where we did not have that much of a good outcome. So basically, the D in DALC, for anterior lamellar keratoplasty to be deep, then bare Descemet's membrane or Descemet's membrane and Dua's layer should be exposed. Many techniques have been proposed to achieve this. The most efficient is Anwar's big bubble technique. It is a little bit challenging when you try to learn it at first, but then when you learn it, it is really a gem. The reason I'm saying this is that I'm one of the guys who tried everything. We've tried viscodissection, we've tried hydrodissection, we've tried the Mellis technique, which is very nice to read and very nice to understand. But when you apply, it is definitely not reproducible. And I would say it is reproducible only in 50% of your cases. unlike the big bubble technique, where you really get the hang of it, it is really reproducible in most of your cases. But early in the day, there were reports of excellent visual outcomes associated with DALK surgery that also left a thin layer of stroma, but very, very thin layer of stroma, which does not exceed at all 100 microns. And this has been reported by various studies, and it was later termed predysmatic DALK. We still believe, of course, sorry, just a second here, yeah. We still believe, of course, that bare Descemet's membrane or true DALK gives better outcome than predysmatic DALK. But is big bubble DALK an easy and guaranteed procedure? It is after some time, after you get the hang of it. The problem with corneal transplants in general, corneal transplantation is all sorts of corneal transplants, endothelial transplants, femtosecond assisted transplants, anterior lamellar transplants, and deep anterior lamellar transplants are really easy surgeries. These are not challenging surgeries like they seem to be. The problem is the frequency of doing these surgeries. For example, when you train one of your junior colleagues on phacoemulsification, you can actually train him like for 10 cases in a row per list. So in a month time, he will be up and running on his own without the need of any assistance. You cannot do this with the corneal transplants for very, very variable reasons. Number one, the scarcity of the sources. You don't have corneal buttons or corneal donor tissue available that much. Number one. Number two is the frequency of the pathologies. It's themselves. They're not as frequent as cataracts, for example. So you do have to have sort of a tertiary center where everyone is referring the cases to you. And then you will see the anterior pathologies and the ectatic corneas and the Fuchs dystrophies and the pseudophakic corneal decompensations in a much more higher frequency than the standard deviation of the normal ophthalmic practice. Now, having said that, even if you're one of those guys that is working in a cornea center where everyone is referring the corneal cases to them, you might not get enough tissue for transplantation. So again, you don't have the frequency or the rate of surgery that will give you a smooth sort of learning experience. And this is the only challenge in all sorts of corneal transplants. So you sort of learn something and then you keep the thought, keep the experience, put it somewhere in your brain and lock it until you do the next time and try to avoid what happened in this time. Maybe next time will be like a couple of weeks after that, 1 week if you're lucky. So it is not as frequent as training on other procedures in ophthalmology. So this is why you really should cherish and understand each and every mistake that you do and how to avoid it. It is an easy procedure when you do it more than, well, let's say the first 20 cases may be a little bit challenging, but after that, there's always, like any procedure, like any surgery, there's a eureka moment where you just do it. Everything is fluid and everything flows very seamlessly without you knowing what happened basically. But until you do that, you will find some hiccups. Again, if you're a very experienced and a masterful corneal surgeon, you will get every now and then complications, of course, like any surgery. And one of the complications in DALK surgery is not being able to obtain the big bubble or to separate clearly the Descemet's membrane endothelial layer from the rest of the corneal stroma. Even after conquering the learning curve, promising your patient that you will perform a successful DALK without conversion to a PKP is still not guaranteed. Up to this very day, I've been doing DALK for quite a bit now. I would say more than 14, 15 years. But until this very moment, I never promised my patient that he will get a DALK. I tell him that he's going to get a corneal transplant, and if I get a DALC, usually when I aim for a DALC, it is a DALC. It finishes up as a DALC, and in these conditions, I tell the patient post-operatively that he had a DALC. But I never promise them pre-operatively that he will have a DALC, for the very simple reason that any perforation can happen, and sometimes you have to convert to a penetrating keratoplasty. When you do that, you don't want your patient to feel that he has been underserviced. So, okay. So what are the challenges? What are the classic challenges in DALC? The trephination should be 80%. If you trefine a little bit more, this may lead to perforation. This happens sometimes, especially in ectatic cornea. It doesn't happen in patients that do have anterior corneal pathologies like anterior corneal stromal opacities. But it does happen when a patient has an ectatic cornea. These ectatic corneas are very soft. Sometimes they do not obey the rule that every 90 degrees of trephination, you will dig in the cornea 60 microns only. Sometimes it's more than 60 microns. So if you do that and aim for 80% trephination, sometimes you will go 100% in one point, and you find that aqueous is coming out and you have perforated the cornea. And when this happens early on the learning curve, usually the defensive mechanism would be for novice surgeons to dig in much shallower and to trefine much shallower. When you do that, you try and go in the depth of the trephination and introduce your instruments, let's say cannulae or a needle, and try to get the air bubble, and you get total emphysema without succeeding in separating the Descemet's membrane from the corneal stroma. And this happens even to experienced surgeons. And the main aim of the talk today is that if you do not have a femtosecond laser, if you're not very well experienced in big bubble DALC, and if this happens to you, then this is not the end of the world at all. You can always finish up your procedure as a DALC, as a deep anterior lamellar keratoplasty, not even a predesmatic DALC, a DALC, where you leave only the Descemet's membrane and a very thin layer of Dua's layer of thin stroma, and you get superb results without separating these layers with an air bubble, i.e. the type 1 bubble. So if you don't have an air bubble, it is not a big deal. It's not the end of the world. You can end this surgery very well, and end the surgery in a DALC form and get the best of the visual rehab. We've been interested in complications of deep lamellar keratoplasty ever since it started. This was one of our very first publications regarding DALC. It was submitted in 2009 and published in 2011 on the common complications of deep lamellar keratoplasty in the early phase of the learning curve. And we actually concluded in this study that perforations are the most common complication that you can encounter when you're starting to adopt this technique. So we actually, what to do, how to avoid perforations, we have described, this was again in 2010, this was a publication in the European Journal of Ophthalmology, where we described a way of getting the big bubble before even trephination to avoid perforations. So we would sort of do a guarded corneal incision in the thick peripheral cornea with a guarded knife, 500 microns or 450 microns. Then we'd go from this incision and inject the air bubble, separate the Descemet's membrane, and then do the trephination. This was one of the modifications proposed at the time. We actually stopped using this modification years and years ago. This publication was 13 years ago. But again, this is just to tell you how much this was annoying us and how much this was in the center stage of the learning curve of doing a DALC, was how not to perforate and how to get a decent big bubble. again, we published a lot on DALC early in the day when we started doing that, and we even published a technique that I still use until this very moment, sometimes in superficial corneal opacities, especially in patients that do have superficial herpetic opacities. And sometimes they do have recurrent herpes for years and years and years. You have this very thin, like 100 to 150 micron deep opacity in the cornea that does not necessitate that you do a penetrating keratoplasty, of course, or even a DALC. So you don't have to remove all the stroma. So you can actually remove 200 microns, 250 microns. And we've published this, and we've actually presented it in the American Society of Cataract and Refractive Surgery, ASCRS. I think back in the day, this was in 2015. So this was basically the rationale without it, about the anterior lamellar keratoplasty using a femtosecond laser. That some reports reported excellent visual outcomes, even with the remaining stroma. And by saying remaining stroma, I did not. It was not termed at the time pre-desmatic DALC, but just leave a little bit of stroma and do a DALC, and you get good results. This was in contrast, or opposing what we used to believe and what we were taught and what we actually experienced when we used to do manual DALC back in the day. Other reports attributed bad visual outcomes, even if you have very good exposure of Descemet's membrane, if you leave the peripheral stromal corneal stroma remnants, and this will lead to irregular astigmatism and sometimes bad visual outcomes. So the regularity of the interface seems the important issue, even if the Descemet's membrane is not totally bared. And this regularity could be achieved by manual dissection using sharp instruments, and you can actually use the femtosecond laser as well. At the time, in our publication, we report at the time, but now we've done like hundreds of cases. Basically, we reported the results of 8 cases of herpetic corneal scars at the time, and we replaced only 70% of corneal stromal thickness. And this was our publication, and this was basically the video. And this is this introduction just is, for me, is important, because I have to say that if you are in doubt, or you don't have, if you couldn't do an air bubble and separate the Descemet's membrane, it is not the end of the world. You can leave some skirt of corneal stroma. You can even plan the patient preoperatively to do something like this, like an anterior lamellar keratoplasty, which is not deep at all. But if you're trying to do this, then definitely do this with a femtosecond laser, because it's an extraocular procedure. You can do it even in the LASIK room, and you can pop in just 4 sutures or 8 sutures. Some of my colleagues, if they go below 300 microns, they don't put sutures at all. They place a contact lens, and you end up with decent results. So these are just some of the photos of the cases that we've done. And actually, if you take a look at the OCTs, this is pretty deep stuff. I mean, if you take a look at the transplanted cornea, you transplant more than in the neighborhood of like 2/3 of the corneal thickness, and in these patients, a lot of them reached 6/6 vision with correction, of course. So what are the variants of deep anterior lamellar keratoplasty techniques? You can do the primary manual DALC, which was first described by Garrett Mellis. This guy is a genius. He is the one who revived all the lamellar cornea transplants, and I truly admire his work, and I truly admire his publications. But again, the description of the technique, of the Mellis technique for manual DALC, is a little bit complicated. Depends a lot on the visibility, on the microscope, on the shadow, and you have to inject air inside the anterior chamber, and to calculate the distances by dividing the distance that you're seeing with your eye by 2. So it's pretty much complicated unless you do a lot of cases, and then you get the hang of it. And when you get the hang of it, when you try to explain this in English, in words, Sometimes it's very complicated, but when you know what you're doing, it's easy. Again, this needs a lot of cases for you to master it. You can do pneumodissection, which is totally different from the big bubble technique. Pneumodissection is basically to increase the thickness of the corneal stroma by emphysema, by injecting air inside the stroma. And then the air, when it is injected inside the stroma, the stroma is a little bit spongy, especially in ectatic pathologies, and you can remove this cornea easily, layer by layer and step by step, until you get a bare Descemet's or Dua's layer. Or you can do a big bubble technique, of course, and this is the obvious. You can do a hydrodissection. A lot of eminent corneal surgeons have described hydrodissection or even viscodissection for DALK. I did a previous presentation on femto-assisted DALK and what are the advantages of using a femtosecond laser if you're doing a deep anterior lamellar keratoplasty technique, and how can you do a lamellar cut, and how you can even do the tunnel that you insert the cannula in to get your big bubble. Or you can even do a pre-dysmatic DALK. You can do a pre-dysmatic DALK if you cannot do anything else. If you try to do a big bubble and you fail, then you can end up with a pre-dysmatic DALK, again with very decent results. Much better than perforating and changing the whole thing into a penetrating keratoplasty. Not much better visual rehabilitation, but much better in potential complications and, of course, a rate of rejections. So this is a video that I've done quite some time ago, and it was about a failed big bubble and how it ended up with manual dissection in a patient that was scheduled for a femtosecond DALK. Okay, so I knew actually I had this video somewhere, so I had to look for it. So this is a patient. As you can see now, I'll stop the video right here. Now, the ring that you're seeing right now is the mushroom ring, and this is after we did the applanation of the femtosecond laser, and we did the docking, and we did the laser cut. So again, we do not aim at perforating the eye at all. I stopped short like 100 microns above Descemet's membrane, and the plan is to go deep inside this gutter and introduce our cannulae and trying to inject the air bubble to separate the Descemet's membrane. And this was the initial plan in this case, but obviously this did not happen. I'll try to run through the video as fast as I can. So this is the blue ring. It's something that I use to avoid cutting the residual, this step as residual corneal stroma. And then you will end up cutting the step, and you will have a deficiency in tissue when you're suturing the donor to the recipient. Okay, injecting the small air bubble in the anterior chamber. Okay, and then introducing the trocar and then the cannula. And this is the cannula. I tried to inject the air to separate the air, but I know immediately, you know, that I did not get the air bubble, the big bubble, and I could not see. I'll just stop it right there, just right there. Okay, I did not see the bubble on the one side, the bubble that I've injected inside the eye, inside the anterior chamber, go to one side. And when you see the air escaping from the step on the other side, you know that you did not achieve the big bubble. Let's see, take a look at this again. Now, this is the bubble. This is the big bubble that I will be trying to take a look at and know. Just a second. Yeah. Okay. So this is the bubble that when I inject the air, I would like it to move in this direction, for example, or in the other direction, so I can see it. If it doesn't move, if I don't see anything displaced, then I know that I did not separate the Descemet's membrane. I did not get the big bubble. The other thing is, when you see air coming out from the step on the other side, then you know that there is an easier plane that the air can escape in, and not through the Descemet's membrane and separating it. So again, okay. So again, the air escapes. Okay, so I started doing the manual dissection. I'm leaving this video. I'm not going to, to skim through this video at all. I'm leaving it. I just wanted to show you how you can do this, and you can actually end up with very good results. So now I know that I do not have the air bubble. What I like very much, every surgeon or every doctor has his own, armamentarium or his weapons that he likes to use. What I use is the blunt fogless trocar. So this is a blunt, not a cannula, because it doesn't have any openings, just a trocar. And I insinuate this trocar between as deep as possible. It is very blunt. It will not rupture the descemet's membrane. So I try to insinuate it in the deep layers of the stroma, just to separate this stroma from the descemet's membrane. Again, you can do this with a variety of instruments. There's something called a wedge resector. There's something called a trisector. There are all sorts of hockey sticks and stuff, but this is what I like to use, because it is, in my opinion, this is the safest and the softest on the posterior part of the stroma. You just insinuate this trocar. It's a cannula that has no holes at all, and whenever you have a plane of dissection, you just dissect it. And now you know the value of the blue ring, so you'll never cut the blue ring at any point. Again, you use the trocar again and again and again. Try to use always blunt tipped scissors, of course. And whenever you get stuck, then go back and use the trocar. At any point, if you decide to leave it and put the graft, you're not doing a bad decision. Again, you are not doing a bad decision when you're that deep and you can actually see areas of descemet's membrane. But try to go deep as much as you can. Don't overdo things. Always remember that the enemy of good is perfect. So try not to overdo your stuff. If you can find a plane of cleavage with the trocar, then go ahead. I'm not going through the video. I'm going to leave you guys take a just to know that it's a different mindset. What's the different mindset? You have time. You have to convince yourself, and of course your staff, that you're staying here for quite some time. So never put a DALC in the early on the list. You can put a penetrating keratoplasty early on the list if you want, but not a DALC, because sometimes you will need manual dissection, and if you need manual dissection, you will need time. Penetrating keratoplasty is usually taken in the neighborhood of 20 to 30 minutes, and DALCs you will increase like 10 minutes or so. If you're doing a manual dissection, this may take up to an hour 15 minutes. So again, this is something that the OR staff are not accustomed to. If you decide to do this, it is time worth spending. So don't give up easily on these cases. Again, this is only just to dissect the plane. You know that you're in the right plane. You try to dissect over the cannula, and if the cannula moves freely, then you're a happy man, because this means that you have separated the layer of the descemet's membrane. And eureka, now you will see that descemet's membrane can be bared very, very obviously and very, very easily without the need of the big bubble. So the big bubble is not associated. It's not a must. You must have a big bubble to bear the decimets and do as layer. No, this is not true. You can actually do this without the use of the air. The air bubble helps you. It's a tool, but again, you can do it without the air bubble. So the rest of the video is easy. Okay, you remove the peripheral part. Again, don't try to overdo the removal of the peripheral stroma, for the simple reason that it has been shown that in this area, there's sometimes abnormal adhesions between the Descemet's membrane and the stroma. And that's why sometimes you get a peripheral perf. If you do get a peripheral perf, it's no big deal. You continue with the DALC. But again, this is not something that you would like to happen in most of your cases. The rest of the procedure is normal or routine. The only thing that you have to know when you're doing a DALC, whether you're doing a manual dissection, whether you're doing a big bubble or any form of DALC, that the tension inside the sutures have to be a little bit more than, you know, the golden hands that you have when you're doing a penetrating keratoplasty, for the simple reason that the Descemet's membrane, the balloon of Descemet's membrane, is pushing the graft away from the interface. And this is something that you need to take care of to avoid opening this potential space, which is the space between the graft and the Descemet's membrane, because sometimes this can invite all sorts of nasty infections. So you have to transplant the cornea and put very tight sutures, more tighter, much tighter than what you are used to when we do penetrating keratoplasties. Actually, when you do penetrating keratoplasties, sometimes it is a rookie mistake to put very tight sutures. But when you're doing a DALC, it's not a mistake. It's always good practice if you are going to do the suturing. I'm a big fan of continuous suturing. I know this is I'm swimming against the current of most corneal surgeons, but these are the sutures that I get the best results with. And the only difference between doing a PK and a DALC in this case is that my sutures should be super tight. And by super tight, I mean super tight. Okay. In these cases, I didn't get, in this specific case, actually it took me some time to find this video, where this video was, I think, a couple of years ago. And when I was preparing for this presentation, I couldn't find the video. So when I found it, I remember exactly when you see an operation or procedure that you've done, you know exactly how did you feel at the time. So at the time when I didn't get the big bubble DALC, I thought that the advantages of having a DALC is over, and I will end up doing an anterior lamellar keratoplasty or pre-descemetic DALC. But this patient ended very well with a DALC. So this is another video. Just a second. Okay. Okay. Again, this is a video of one of my colleagues, and it shows that you can actually dissect again the corneal stroma without the need of the air bubble. He tried to get the air bubble. This was a manual DALC, of course, not a femtosecond laser. Again, he is using a trisector in this case, and if you are accustomed to use a trisector, then use it. If you're accustomed to use a Fogla cannula, a blunt cannula, then use it. People may use scissors only, and this is actually very good if you have the right type of scissors, not blunt at all, and curved. If you can do that, then you will end up again with a very decent result. Again, in these cases, you don't need a blue ring because it's not a mushroom side cut architecture, but you can see that you can actually bear Descemet's membrane and really bear it without the need of the big bubble. So the big bubble is there to help us, guys. It is not mandatory, because a lot of people think that if they cannot get the air bubble, if they cannot get the big bubble and separate Descemet's membrane by Anwar's technique, then you cannot do a DALC. So DALC is big bubble and big bubble is DALC. This is not true. The big bubble has aided us a lot. It's a very, very good tool if you decide to do a deep anterior lamellar keratoplasty. But if you do not have this tool, it's not the end of the world. You can actually do manual dissection and end up, as you can see, as you saw in my last video, and as you can saw in Professor Ahmed Sharif's video. This is video of my colleague, Professor Ahmed Sharif, and he can actually bear the Descemet's membrane very, very decently and very elegantly without the use of an air bubble. Okay. The rest of the video is business as usual. So, okay. Oops. Sorry about Okay.
One note, Dr. Hosni,
Okay.
that whenever you're dissecting, you're starting from the periphery because it is we
It's
have more
easier
tissue
and
there.
quicker.
Yeah.
Yes.
Yes. Yes.
Of course. Of
Exactly.
course. Now, when you're but sometimes, you know, the rules of the game is given to you according to the, you know, what you're facing. Sometimes you have a thick part of stroma in the, not in bang in the center, but, you know, paracentrally, and you can actually from it you can go insinuate a blunt instrument, whatever the instrument you're using, Dr. Bara, and you can actually find the plane of Dua's layer or Descemet's membrane. But sometimes you cannot. So this is, it all depends upon you know, what you're facing. But the message is clear. The big bubble is a good thing, but it's not an absolutely necessary thing. If the big bubble taught us that when you bear the Descemet's membrane, then you will definitely get much better results. But again, if you don't have a big bubble, you can always try to bear the Descemet's membrane and get the same results. So just trying. Okay. So again, this is another video of another colleague of mine. These videos are very hard to come by because in our settings, most people, when they intend on doing a big bubble, they always get a big bubble. So again, this video, you can see that the bubble that was inserted in the anterior chamber did not move to one side, and you cannot see it on one side. So my colleague here, Professor Mohamed Hosny, decided to do this because he had a partial air bubble. So the big air bubble separated a small part of Descemet's membrane, but left the rest attached to the posterior stroma. He didn't have the leverage of a good bubble that you know, separated the whole Descemet's membrane. So part of the Descemet's membrane was separated by the bubble, but the rest was still attached to the stroma. He had to find the plane there, and with the blunt scissors, this is a brave guy. So he's not using any sort of instruments. He's not using a wedge resector. He's not using a trisector. He's not using a cannula. He's using his scissors, and these scissors for me look a little bit dangerous and not blunt, but he's a guy that has, you know, masterful skills and golden hands. So basically this is how he managed this case. Again, with all these mishaps, and maybe he did not have the scissors that he wanted to use, with these scissors he could bear Descemet's membrane all around and transplant the anterior stroma and end up with very, very good results in spite of not getting the perfect big bubble. So if the big bubble fails, or even if it is not planned from the start, manual dissection can give the same outcome. It just needs more patience and more finesse in your technique. There are all sorts of different instruments, but you should try a couple or two, and you should always have them with you, because there is never a guarantee that your big bubble DALC will always be separated by the big bubble. It might need the aid of instruments. Okay, so just the final pearl for manual dissection, if you're going to do a DALC, is when you're preparing for manual dissection, when you're preparing for a DALC, always prepare yourself for the probability of doing manual dissection. You should always be prepared for this. How would you be prepared for this? You should be prepared with available instruments. So you'd have like a set of instruments that probably you will not use, but every now and then you will use. So you have to have the instruments for manual dissection. You have to have available mindset, because we all know in ophthalmic surgery in general, there's a tempo in each and every operation. If you're doing a phaco, if you're doing a LASIK, or if you're doing a vitrectomy, there's a tempo. If one step takes a little bit longer than than what you're used to, sometimes the surgeon, loses his temper and loses his cool. This is something that you should really avoid when you're doing a DALC, because there's always the possibility that you will not get a big bubble. So keep your cool and accept the challenge. With available instruments, mind you, we've done so many big bubble DALCs. So it is not news now. If I show you, not like back in the day, if I show you a video of mine doing a big bubble, so what? No big deal. But actually, when you fail to do a big bubble, then this is a video to keep. So this is a plus point, or the good side of the story, that when this happens, tell the guys, okay, guys, connect the USB because I really want to record this. So keep the cool, accept the challenge. You have to be prepared with available time. So never put a DALC early on the list. I put it last on the list, or even in a separate list, in a separate day where you have, like half day OR session with only 2 or 3 cases. You'll be off and you will finish them up all in 1 hour. But again, you will have abundance of time, so you'll not be worried and you will not be hasty. Inform the staff that this is a probable scenario. This is the probable scenario. So if you get away with an air bubble, you become the hero of the day for all the nurses and technicians. But if this does not happen, then this is what you've told them, that we are going to do manual dissection, guys. And you just try the air bubble and see if it works or not. Finally, as in any planned DALC, try to avoid over dissection of peripheral residual stromal tissue. This is the most common cause of Descemet's membrane perforations. Now, the complications in DALC are many, and the complications early on the curve are many, but these are things that are really highlighted when I'm training, when I'm talking to my junior colleagues who are starting to do DALC. Avoid over dissection of peripheral residual stromal tissue. This is the most common cause of Descemet's membrane perfs. If you encounter severe fibrosis or attachment in the very deep stroma near the Descemet's membrane, just leave it. Remember that pre-descematic DALC is way safer than trying to remove this fibrosis, opening up the Descemet's membrane, especially if it's in the middle, and then having to convert to a penetrating keratoplasty. Now, you always postpone the removal of the donor Descemet's membrane until you have a bare Descemet's membrane of your own for the recipient. So do not remove the Descemet's membrane, and then you will have a Descemet's membrane rupture, and then you will need another graft to do a penetrating keratoplasty because you've removed the Descemet's membrane from the donor. So always keep this step until you have a bare Descemet's membrane of the recipient. And when you remove the Descemet's membrane of the donor, now this is a challenge. Why? Because you've done your job, you're so happy. The climax of this procedure has been done, and you have bared the Descemet's membrane of the recipient cornea. So you want to get on with it and finish it up. So usually what you do is you remove the Descemet's membrane in the donor cornea in a hasty way. Do not do that. Try to do a preparation for a DMEC, even if you don't have a DMEC, even if this graft is not suitable for DMEC, it doesn't have abundance of endothelial cell density, but try to imitate as if you're doing. Why am I saying this? For the very simple reason that I've said in the presentation, that these are procedures that are not so frequent that you can train a lot in. There's no abundance of tissue and there's no abundance of cases. So now you do have an opportunity to pretend as if you're doing, a Descemet's membrane removal for a DMEC surgery. And the DMEC is basically 2 things: unfolding and preparation. So this is it's always a good chance for you to practice preparing a DMEC graft. The last thing I would like to say is that DALC sutures should be much tighter than PKP sutures. These are things that comes with the package. You have to know them. You have to have 2 modes. in your suturing techniques, if you're doing a PKP or if you're doing a DALC. We've actually learned this the hard way when we had persistent edemas in patients with DALCs, for the simple reason that this potential space is not snug enough and it is not snugly fit the donor stroma or the donor graft with the recipient Descemet's membrane. Thank you so much.
Thank you very much, Dr. Hosny, for this wonderful lecture. As usual, amazing, very informative. Like whenever you started the lecture talking about the learning curve, and actually every step you mentioned, every cornea surgeon is really like following these steps.
Honestly,
So,
but we still
yeah.
have these complications after hundreds and hundreds of cases. And this is something that you should be prepared to. And it doesn't make you a lesser surgeon or, a lesser ophthalmologist at all. The only thing that makes you a lesser ophthalmologist or lesser surgeon is not being prepared for what is happening. And believe me, a week out, you will not know the difference, or you'll not even remember the patient that you did manual dissection for and the one that you got, the snappy big bubble in.
Yeah. So we're waiting for a few questions from the participants, and in this time, I will ask a few questions if you don't mind.
Yeah, of course.
Yeah. So usually, how much bigger or what is the diameter of the graft that you cut for a dog?
In
You cut
DALC,
yeah.
Yeah, if I'm doing a manual DALC or I'm doing a femto DALC, these are two different animals. But if I'm doing a manual DALC, I will definitely do an 8.5. And in the donor, I only make the difference of 0.2, not 0.5 or 0.3 like we do in a penetrating keratoplasty.
Yeah.
You see,
So
the problem, the problem, is that when you do a penetrating keratoplasty, you have an open anterior chamber. So you actually place the graft freely, very easily, edge to edge. And the challenges are basically not to put an undermined graft. So if this is the recipient and this is the donor, try not to put it, undermined like this. Sometimes you can put it an overriding graft, and this is again not very good, but to make it flush is very, very easy. When you're doing a DALC, you have this balloon of Descemet's membrane, and you put your graft on it, and it sticks out. So by just putting, the sutures to do apposition of the edges, sometimes the sutures loosen a little bit. And on the second day post-operatively, you will see that the graft is a little bit loose. And this is dangerous. It will either lead to persistent graft edema or infection. And these are two bad things. Again, the graft also is a little bit edematous when it comes out of the Optisol bottle. So it will dry up. So you need the sutures to be super tight.
Yeah. So especially the new note that I learned, you have in the periphery not to go very far, as you said, because there are attachments and you may perforate.
Yes. Yeah.
So that's also emphasizes why we should do almost the same or a little bit bigger, because if you do it 0.5, it won't get down because you have
you have this potential dome under excess tissues.
So in the follow-up period, how does it differ from PKP? When do you remove the stitches? Do you stop the steroids earlier, or can you just tell us a little bit about the follow-up period?
Now the incidence, we all know, of course, that the incidence of rejection, stroma rejection after DALC is very, very low. So my basic regimen after these operations is the basic regimen after cataract surgery. So I give like the steroids for like 3 weeks, and that's it. I don't give, and I don't give oral steroids at all. In these patients, I just give dehydrating agents. I give dehydrating agents a lot, like hypertonic saline and stuff of the sort. And this I used for a whole good 1 month. And then after 1 month, I switched to very low fluorometholone or something once a day for a year, and that's us. I removed the sutures 6 months out.
You start with the interrupted sutures.
Usually I only, in my practice, in my hands, I only use continuous suturing. So I remove the sutures after 6 months.
Great. One Dr. Manuela is asking, do you use blue to color and enhance stroma in the manual dissection?
No, Dr. Manuela, the blue ring that I use is because when I'm usually what I do is femtosecond out. So it's like a mushroom design. It's a complex design. And we need this mushroom configuration and this step, this shelf. I need to see it. After I inject air, sometimes the whole cornea becomes emphysematous. Whether I get the big bubble and separate the Descemet's membrane or not, you find out that there's a lot of emphysema. So when you're trying to remove the rest of the stroma and make the Descemet's membrane bare, then I want to know exactly where is my step of the mushroom. So what I do is I start by coloring the step all around, so I will not snip it with my scissors, thinking that it is residual corneal stroma.
That's great. Dr. Safa Jihad is asking, are there any particularities or special tricks in the PMD or keratoconus?
Basically, Dr. Safa is a good friend. Basically, all of these cases, most of these cases are keratoconic patients. Now, if you have pellucid marginal degeneration, there are pellucid marginal degeneration-like patients or true PMD patients. Now, true PMD patients are really a challenge because they have very thin peripheral corneas. And in these patients, I do very large DALCs or even a penetrating keratoplasty because you do not have enough tissue in the inferior cornea. Sometimes the peripheral cornea is in the neighborhood of like 200 microns. And if you do have, you cannot perform a proper shelf in a very thin cornea like this. In these cases in specific, thank God these are rare cases. We don't see them all the time. But when we see them, then I would definitely go for a very large DALC. In these cases, I would not use a mushroom architecture. I would use a regular cylindrical cut, or I would use a very large penetrating keratoplasty.
Great. Also, Dr. Manuela is asking again, in case of Descemet membrane detachment in the early post-op, what is your management?
Okay. Now, early DM detachments in the early post-op usually happen with perfs. They never happen without the perforation. And this is double anterior chamber. This is a very common, classic sort of complication of deep anterior lamellar keratoplasty. And this was one of the reasons that central perfs were always advised to convert to a penetrating keratoplasty in these cases. I don't do this now. If I have a central perf, I would definitely continue with a DALC. For the simple reason, when we used to say central perf convert to a PK, this was before the era that we did DMEX. And now we know that even if you have a very thin part of the Descemet's membrane, it can actually do the job of a whole Descemet's membrane. I have presented a couple of cases actually. Unfortunately, they were not published, but similar cases were published by Nayak Navanati in the UK, and these were in patients that had a persistent double anterior chamber, and they dropped off in follow-ups. They did not come for the follow-ups, and then they turn up later on, like 6 months out, with a perfectly clear cornea, because the endothelial cells have been shown to sort of grow and migrate over the posterior part of the cornea, in spite of the Descemet membrane is not in close proximity or attached to the posterior stroma. But having said that, if you do have a Descemet's membrane detachment or a double AC in the early post-operative, I would definitely go and rebubble the patient, exactly like rebubbling a patient of a DMEC.
Great. Uh, for new surgeons or fellows who are starting DULC, do you prefer to start with the big bubble or the manual dissection?
No, big bubble, of course. Big bubble, of course.
Of course.
You need to learn how to do a big bubble. And the manual dissection is like plan B, is something that you have in your armamentarium, in your back pocket, if the big bubble doesn't work.
Great. When injecting air in the AC, we see some surgeons put it just at the beginning, or they delay it until they have the bubble. So when and where do you prefer to do the side port?
First step, the reason why, because if you decide to inject after doing the air bubble, you have to be very cautious and you have to be a very experienced surgeon. Why? Because you do have this big bubble that you have achieved. If you go parallel to the iris plane, you can easily, very easily puncture the bubble. So you have to go, you know, in a very sort of perpendicular way, as if you're aiming for the optic nerve. And this is something that some surgeons is not second nature to them. So I always advise that if you're going to do this small bubble to see it, you know, pushed to one side with the sausage shape, then definitely do this first step. And don't overfill the anterior chamber, because this will resist the big bubble from separating the descemet membrane. Just put a tiny small bubble or two to make sure that you have achieved the big bubble when you achieve it.
And actually, if you go to plan B, you will know the depth. So you see the you see the bubble and you will know the depth. Yeah. Where do you usually do the paracentesis? The side port cut?
At 9 o'clock.
Because sometimes when you take the sutures, you may open the
Well done. This is a good point. But this is something that you should learn to avoid from the very first day, even if you're doing a good old penetrating keratoplasty. Because if you remember classic teaching of penetrating keratoplasty, we used to start off with a paracentesis and inject a lot of viscoelastic in the AC, so you can have the enough buildup of pressure, and during trephination you get a very sort of a regular through and through cut to the AC. But yes, when you go to the 9 o'clock, especially if you're using a continuous suture, you have to be very clever to avoid this paracentesis. And sometimes, even when you avoid it, by tightening the suture, you open it. So sometimes the paracentesis needs a separate suture. But this is a very smart question. But this is the place where most of us do the paracentesis.
Also, Dr. Manuela is asking, in case of mixed bubble, do you convert in viscodissection?
No. When you mean mixed bubble, you mean type 1 and type 2. I just burst them open and change it into a type 2. It's easy. You see, what is a mixed bubble? The mixed bubble is a bubble that has separated the Duas layer and descemet membrane from the stroma in one part, but in another part, it went inside between Duas layer and the descemet membrane, so it separated the descemet membrane only. If this happens, I just open up the bubble and convert it all into a descemet membrane, and this is very, very easy. But the thing is, you have to be very careful, because descemet membrane, when it is truly bared without the Duas layer, it's a very fragile membrane. You can open it up even with blunt instruments. I've seen descemet membrane rupture from irrigation. So sometimes sharp irrigation can do that.
A lot of people are thanking you. Impressive work. Someone saying, facing the failed big bubble with a calm and determined mindset. Bravo. Great talk as always. Thank you, Professor.
Again, Dr. Safa is my friend. She's just being courteous. She's supporting me.
Actually, on behalf of Dr. Mazen, I would like to thank you, Professor Mohamed Hosny, for this wonderful talk as usual. And looking forward for next meetings.
Inshallah, it's always a pleasure to see you, by the way.
Thank you very much. Thank you, Dr. Mohammed. It's a pleasure.
Good night.
Bye-bye. Good night.
Bye.
Good night. Good night, everyone. Thank you.